milestones and the ensured professional activities. And the whole idea of how do we assess competence now has come to the forefront. Although the simulation lab has been used for quite a while for procedural competencies, there are also principles of simulation learning that can be applied in other settings, and the sim lab can be used for many other things besides just procedural competency. So this whole area, I felt Dr. Eason was probably our local expert on competency assessment, so I asked him to look at what he had done educationally and put this talk together to give us an idea of how we can move forward, better assess competency in the various areas that we need to determine whether or not someone has reached the level that they're ready to be independent providers. Okay, Dr. Eason.
Thank you, Dr. Tracy. I always like to know my audience, so residents, raise your hands. Attendings, a few. Okay, great. So I knew who I'm talking to anyway. I took a shower this morning, so if you want to come forward, you can. You don't have to. When Dr. Tracy asked me to give a talk, I wanted to give something exciting, like how not to get sued or giving a deposition. But no, he wanted an exciting topic like competency assessment. So you guys are mostly the assessees, but soon you might be the assessors as an attending. And so what I'm going to do today is I'm going to talk a little bit about what drove us to where we are today, discuss some of the aspects of assessment, the uses for it, and then maybe give you guys a little example of how the process in which we do it. Now, I'm going to tell you up front, full disclosure, there are no easy answers, okay? It's extremely challenging. I go to the international meeting every year, and that's the big struggle, is how do we decide what's good enough? So I have nothing to disclose that's pertinent to this presentation today. All right, so I hate to lecture, so let's start with you guys. Why do we assess? Give me one reason.
Ascertain what a trainee knows.
Okay, what he knows, he or she knows or doesn't know. So learning gap analysis. Excellent.
Try to develop competency, figure out what kind of product you're making.
Determine competency. Excellent. Oh my God, because hold that thought, because it's required by ACGME. How about you? Why should we assess? So a baseline. Okay, where do we start? Okay, so level of knowledge. Okay, those are all awesome reasons. Why is it so hard? Those two guys just climbed El Capitan a couple weeks ago, free climbed. Not this guy, I don't know if this guy did it, but it was on the news. I think that's just so incredible. Why is it so hard?
It's expensive.
It's expensive, so logistics, right? It's impractical. Why is it so hard?
To have something that's universal so that everybody's on an equal playing field.
Because it's hard to reduce variability. Excellent. Someone give me another reason. Why is it so hard? It's time consuming. Yes, I hate it. Right? And a myriad other reasons, right? How do we decide what's good enough? How do we quantify quality? Right? Those are all really challenges. But you know what? We all have to do it, right? We all have to do it. The RTs, nurses, physicians, pharmacists. It's the world in which we live in today. And we hate it, right? Name me one of you guys here who loves being assessed. Anyone? What about our attendings out there? Who loves to assess? Who finds joy in judging? Right? It stinks, but we all have to do it, right? Why don't we like it? Why don't you like it? Okay, but we just said it ensures learning gap analysis. It ensures competency, right? But yet you don't like it. So there's a dichotomy there, right? That's why we all struggle, okay? No one likes to be judged. But we're all here today because we've passed a bunch of assessments, right? Well, some of us. Okay, so let's talk about history. How did this all come about? Why are we here? Well, competency-based medical education has been, as Dr. Geraci knows, because he and I have been around for a while, it's been around for decades, right? It just ebbs and flows. But when the Institute of Medicine report came out to Err is Human, and they showed how people were being hurt, competency-based medical education all came back. Perhaps if we assessed our healthcare providers and ensured that they were competent, maybe people wouldn't be hurt so much, right? I love this slide. My bad. Oops, I just stuck the carotid. Huh. You guys have never stuck the carotid ever? Wow. Okay. Should we take 5 minutes for more coffee? No? I'm dying over here. I have lots more cartoons. Okay, so, people sat around and they looked at the report and they said, you know what? We need to have some standards so that people get safe, timely, effective, efficient, patient-centered, and equitable care. That's sort of what's driving this, right? We want to make sure that our end users receive the product that they paid for, okay? So it's back again, competency-based medical education. So ACGME, the Canadians, they have something called CanMeds, the Brits, the Dutch, the Center College for Medical Specialties in the Netherlands, they all promulgated these standards by which we should practice. So how do we do this? Well, first we have to identify what competencies need to be addressed. And then within that, you have to decide what components of those competencies can we truly assess, because you can't measure something unless you know what's in it. And then you have to assess those competencies. And then lastly, go back and go, are you doing what you're supposed to do? Okay? So that's the process that's been going on for the past decade. All right? And so these are three ways in which we identify the process in which a physician or healthcare provider works, right? So you have Miller's pyramid. It's cognition, and then it goes into skills and action. Everyone knows Bloom's taxonomy, so it's cognition, behavior, and then attitudes, and then the Demo-Median system, where you break it up into processes, where this is the healthcare system, this is what we do to our patients, and then this is what happens to our patients. So these are ways to identify what it is that we do, right? But just because we identify what it is that we do doesn't mean that we can actually decide what we should measure. So that's been the challenge, right? But for our society, our accreditation folks, they decided on these core competencies. And you guys have probably heard about these till you're sick of it, right? So patient care, medical knowledge, practice-based learning, interpersonal communication, systems-based practice, professionalism. How many of you guys know, if I asked you today, could identify exactly what each of those terms means? Seriously, right? And you know what? I'm not going to judge you, right? Because it's challenging, right? And you know what's not fair? This is how we assess you. And yet you couldn't tell me, I didn't see any hands come up, right? As to what each of these means. These are your core competencies. This is what you see your program director twice a year for. You know that, right? Okay, good. So we're starting at the basic level, Dr. Geraci. All right, I thought I was going to bore you today. I still might bore you. So, all right, so let's talk about it. So patient care, so it's about how is it that we take a history? Do we formulate a differential diagnosis? Do we generate a good plan, right? Medical knowledge, do we have enough foundational knowledge to do number one? Because if you don't, you can't do number one, right? And so that's your in-service, right? That's your board. Practice-based learning. At work, do you reflect on your actions? Do you think back about what you did so that you could do it better next time? Okay, so that's a sample of that. Can you communicate with your team members to effectively deliver care? Can you share with your patients your thoughts and plans so that they can participate in their care? All right? Systems-based practice. Do you know the healthcare system in general? Do you know how to use the services available to you in an efficient and effective manner? Right? What social work is out there to optimize your patient's care when they get home? How do you order labs efficiently and inexpensively? Then last but not least, professionalism. Are you ethical in your practice of your patients, right? As an attorney, right, I recently helped a lawyer sue a cardiologist who did 500 unnecessary catheterizations, right? Why? Because he was getting paid. I would consider that not professional, right? So we start with the core competencies, right? But now we take it a step further. Now within the core competencies, we have to assess you on a continuum because we anticipate that as you go from the PGY1 year to the PGY4, PGY5 year, you're going to accomplish more and more, hopefully, so that by the time you finish the continuum of practice, you have achieved almost the aspirational part of the milestones. So every residency program, every specialty has to do this, okay? And the whole rationale behind doing this is that behind competency-based medical education is we should not determine that you're competent because you've been here for 4 years. We should base your competencies by the fact that you've achieved all these milestones. Does that make sense? But you know what? When you're done with residency, you're done. Which is for me there's tension there, right? Because we still have time as a constant. So as your attendings, we're forced to make you competent, right? And that's very challenging because people learn at different pace, right? You probably finished residency in 1.5 years, right? Okay, 6 years. Right? And so your program director, not Dr. Geraci, because he's very honest, he's going to look at you twice a year and go, okay, PGY1, let's talk, let's see. And then he meets with 2 of his committee members. And they go, well, right now this young resident is a 3, right? But other people, like I have a friend whose name I won't mention, he's a program director. He says, oh, PGY1, let's see, 2, 3, 2, 2, 2, 2, 2, 2. Because he has to do this twice a year, right? And then he shares it with his 2 buddies on the competency committee, and he says, what do you think? And they go, yeah, right? That's not right? But that's the pressure we live under, right? Dr. Geraci probably sits down and goes through with you guys individually because he wants to make sure that by the time you reach your PGY4 year, you are ready for practice. All right, so what is competency? Someone tell me what competency is. Tell me what competency is. I'm looking at you, babe. Yes. What year are you? First year. All right, so you're just in it, right? So you're striving for competency. What do I mean? Hard, yeah? Hard, right? All right, so Oxford English Dictionary. The ability to do something successfully or efficiently, right? I want to make sure that you can do something right, right? For us, that means logical sets of general qualities that every physician should have. What the hell is that? What does that mean? right? I can gestalt it, you know, because when I do my case reviews as an attorney and a physician, I say, they should have done that, right? But I've been around for a while, all right? So the next step, so we have our core competencies, we have our milestones. So now the new thing is entrustable professional activity, right? Those professional activities that together constitute the massive critical elements that operationally define a profession. A unit of work that should only be entrusted upon a competent enough professional. In other words, can you manage acute coronary syndrome? Right? Can you deliver an uncomplicated pregnancy? Right? The Dutch are really hot on this right now, right? And check this out. If you have achieved that level of competence, you're awarded a statement of awarded responsibility, a star. Who came up with that crap? Like someone wrote a paper on that, I'm sure, and got promoted, right? But seriously, that's what you get. You get a star, okay? So let's break it down. So this is a little matrix, right, for obstetrics. So you've got your core, you've got your entrustable professional activity. Within that, you have your core competencies, right? And so this is how we match it up. And subsumed within that are going to be your milestones. I don't know why Dr. Racing doesn't just kill himself twice a year. You know, this is crazy, but this is what we live. This is how you guys are assessed, right? And once you get the EPAs for internal medicine, right, this is the matrix that we have to develop as a program to assess you. And you guys need to know this because this is the standard by which you'll be judged, right? All right, so we have core competencies, milestones, EPAs. I don't know what's next. I don't. So I love this. And I show this slide because slow readers. Because, in anything we do in medicine and science, we test a hypothesis, and we make sure that we prove or disprove it before we formulate a plan, before we make people do it, right? No one has determined whether these core competencies, or even EPAs for that matter, has changed patient outcome. No one. And we make everyone do it, which is like so backwards. Someone said it takes a lot of time. I'm not saying we shouldn't do it. I'm just saying, maybe we should think about it before we make everyone do it. That's just my opinion. But that's the world in which we live in. All right. So what's the purpose of assessment? So we talked about competency. Someone mentioned competency. Instructional effectiveness, right? If I'm teaching you and we go through a simulation and you don't seem to be doing it right, maybe the problem doesn't lie with you, but it lies with me, right? So when I'm in the simulation lab, and some of you have been in there with me as students, something that I think you should know you don't know makes me think as an instructor about maybe how I delivered that information. So it's about making me better, okay? Gap analysis, learning needs, benefits to the learner, behavioral change, right? If you're doing something a certain way and I want you to do it differently, I can assess you. And instructor effectiveness, as I said. All right, there's two forms, right? When you do an assessment, it's a form of a trial. So is it a test to discover the worth of something? Is it a no or no-go, right? This was a test a couple Sundays ago, right? Right? Is this too soon to show this slide? No? A bit too soon. Right? He should have covered that guy. Obviously, he failed the test because he is going to the Super Bowl and he's not. All right? The Green Bay Packers needed to play for 60 minutes, not 58 minutes. They failed their test. All right? The Seattle Seahawks, on the other hand, did great on the final. Well, not yet, the midterm. The finals this Sunday. Right? Or is it a test to improve the worth of something? Right? Do we use assessment to make you better? Okay? Like a scrimmage. Or in this case, this guy is, making this sword harder on the forge. And the sword doesn't like being pounded, but he's going to be grateful for it at the end because he's going to be harder. Does that make sense? All right? So these are some of my former students. we're doing a trauma here. And when I'm in the sim lab, all my assessments are formative. I can count on one hand the times I've used simulation to do high stakes, and it was for somebody else. It was never for me. All right? So by assessing my learners, I can see where they can improve. Okay? So you could break it up into two kinds. Formative assessment is lower stakes, and it's one of several assessments over time, and it can be evaluative, diagnostic, or prescriptive. What do I see wrong with my curriculum? What can I do to make my students better? And what steps should I take to make their behavior change? And so either I need to remediate, or we can go on to the next step. Okay, so this is formative assessment. This is how I do simulation most of the time. And then there's summative assessment. It's higher stakes, so it's like a final. It's a board certification, all right? So the primary purpose is to determine whether you are safe or competent, and often results in a go, no-go outcome. So just some clarification, we use the words evaluation and assessment interchangeably, and in the layman's terms, they are kind of in the same. But from a pedagogical standpoint, assessment is how is the learner doing, and then evaluation is how is the teaching program doing. Okay, so an evaluation is about how I'm teaching you, how effective am I, and an assessment is how is the student doing. So whenever we talk about measuring student progress, we use the word assessment and not evaluation. All right, so I want everyone to take 5 minutes and come up with an assessment tool for intramuscular injection. Go ahead. You guys have given IM injections, right? So just take 5 minutes. Just write down how you would assess someone doing an IM injection. And then I'll take a volunteer. Better get my equipment ready. Are we done? Still writing? Come on, this is a thought exercise. You can't be lazy on me. Wait, don't say it yet. Come on, you're volunteering. Come on down. Yes. Yes. No, I'm doing it. I don't want to judge you guys. I'm doing it. Come on. Sit right there. I'm going to give you an IM injection. Sit. You shouldn't have raised your hand. Sit. Hey, I'm Dr. Eason. I'm going to give you a shot. How are you today?
I'm good.
They're your friends, so we don't have to worry about HIPAA. Didn't know you were going to have to do this today, did you? Ready? Owie.
Aye.
There you go. All done. How was that?
Cool.
Okay. Did I pass? Who says I passed? Who says I didn't pass? Okay. Thank you. Big hand for this guy. Thank you. Okay. So you guys say I did not pass, right? So, all right. So I didn't pass, right? So that was a global rating scale, right? I didn't pass, right? Yes or no, right? Okay. So we have checklists, we have global rating scales, and then we have anchored rating scales. So Did you make one?
Checklist?
So you made a checklist. All right, and so you had a list of things I should have done. All right, and in your checklist, were there like, if he fails this step, he fails the whole thing?
Correct.
Okay, so you had like certain no-go steps. Okay, all right. All right, so this is Miller's pyramid that I mentioned earlier. And basically, this is cognitive, and this is skills, right? And so for you guys, this is written tests, right? And then for me, this is OSCEs and simulations. So this just shows how, and then does. This is in the clinic where your attendings actually, they look at your portfolios, they interact with you. Problem is there's so much variability here that for me to really test you and control the variables, control, is at this step, and that's where simulation is. All right? So the question when you develop an assessment tool is, are you measuring something or are you judging something, right? And I'll show you some examples, all right? And that decides what your assessment tool is, right? So under the shows how part of Miller's pyramid, if you're measuring a process or outcome, you make a checklist. So you are measuring something, right? If you're judging something, you use a rating scale, okay? Well, aren't they the same thing? Actually, they're not. So let's look at the two different things. So checklists measure outcome. They measure a process. They reflect best practices. Maybe I should have put a Band-Aid on him afterwards, right? Maybe I should have wiped off the little bottle with alcohol before I aspirated it, right? So they're used for specific tasks, clear rules. They're more reliable, but less valid. We'll talk about those two terms in just a second. Rating scales judges a process and judges the outcome. And they reflect a consensus because it's not a clear-cut answer. And is used for complex tasks, more than just giving an IM injection, okay? The rules are less clear, they're less reliable, but they're more valid. We'll go into that. And so the question is, should the learner experience, and in other words, the novice versus expert, affect the assessment tool that you use? All right? So let's talk about the two. The checklist may reward thoroughness rather than competence. Checklists cannot recognize out-of-the-box thinking because it's just a bunch of things you're supposed to do. A checklist mimics a novice's approach to a problem. Experts may not be thorough, but more accurate in problem solving. So let's give you an example. An expert will quickly come to a conclusion about a diagnosis and know what to do. They may not be able to explain to you how they got there, but they usually get the answer right more often than not. Okay? If you do a checklist, you can't tease that out, okay? And if you use a checklist, minimal differences between a novice and more advanced learner when you just use a checklist, right? So that's called construct validity, and we'll get into that in just a minute. In other words, you can't tell the difference between an expert and a novice by using checklists. It's more difficult too. And if you have someone who's an expert rater, someone who's assessing you, they can recognize someone who's more advanced. But if they use a checklist solely to determine your competency, they won't be able to rate that. So a guy named Reger did a study back in 1998. It was a surgical procedural study where they had 8 stations, and they all simulated surgical procedures. And each resident was supposed to go through each procedure, and there was 2 ways to evaluate them, with a checklist and a global rating scale. And the checklist was, cleans wound, sutures, uses this type of stitch, blah, blah, blah. And the global rating scale was efficient use of instruments, uses assistance properly, takes care to not injure tissue. Things that you can't do on a checklist, or you can only observe and watch, right? And so they had two raters for each resident. One rater uses just a global rating scale, and one rater used both a checklist and a global rating scale, and then they compared them.
Dr. Eason,
Yes.
I have a question about that. But within that checklist, I mean, what you're describing to me almost sounds like a checklist with implied grading within it.
Right.
Within it.
Yes.
You have a checklist, and then
But it's
the
Gestalt.
interpretation of the product.
Exactly.
So it's both. It's really
Well, and I'll show you how it's, so it's called an anchored rating scale. I'll show it to you, all right? And so what they found was the checklist did not improve reliability or validity, all right? But the glowing rating scale showed higher interstation reliability. In other words, if you did badly on one station, it's more likely that you would do badly on another station. You had better construct validity. Construct validity is, does it measure what it's supposed to measure? So if you're a fifth-year surgical resident, you're going to do better than a first-year surgical resident. And the checklist didn't show that as well as a global rating scale. And, oops, sorry. And better concurrent validity. And what that is it predictive of success? So if you do a good job, not using the checklist, but in how you manage your instrumentation, how you manage your assistants, the end product is how the tissue looked at the end was better predicted. So in this study, the global rating scale was actually superior than the checklist, right? So what does that all mean? That means that when you have a novice trainee or learner and they're doing basic things, a checklist is better. But when you get to the expert level, it's better to use rating scales because there's a lot of things. There are certain motions that you use that you can't just say, okay, because the checklist is yes or no, did this or did not do that, right? The other stuff is more subjective, right? Took care of tissue. What does that mean, right? So give you an example. So checklist, so these are code steps, right? Notes apnea, listens for breaths, correct mask size, obtains good mask seal, ensures chest rise, right? So this is a global rating scale. What is your opinion of this presentation so far? I sucks. I would see it again. I record it and I watch it every Saturday, right? But the problem with a standard global rating scale is that it can introduce bias. And certainly there's inter-rater variability, right? So we do something better now. We do what we call an anchored rating scale, which is what you're speaking of. So basically you have a way to quantify the quality, right? So there are descriptions attached to each rating, right? So if you use checkback, you close the loop for all critical orders, you get a 5, right? So it's kind of like your milestones in a way, yeah? Because there's anchors. So this is what we use now, all right? So the death of any assessment is the inability to interpret data, okay? So, and if you have too much variability, the data are worthless. So I stole this slide from Paul Frampus at Weiser. I think it's kind of neat. So when you assess, you have student, evaluator, so you have these confounding factors. You have the assessment tool itself, then you have your patient, all right? Let's say your standardized patient in an OSCE. Are they responding appropriately, blah, blah, blah. And balance between reliability and validity. So let's talk about reliability first, right? The extent to which an assessment consistently and accurately measures learning, right? Does a tool give you the same degree of accuracy in the results each time, right? So let's use an archer, right? Archer hits the outer ring every time, right? He's very reliable, right? He's very reliable. Archer 2 misses the mark. So Archer 1 is reliable, not Archer 2, right? So when we say reliability, we mean consistency across time. If you give a group a test one day and then 6 weeks later you give them the test again and you get the same results, those results are reliable, right? Across tests, you have 2 tasks that measure the same skills, right? The results should be the same, right? And if you have multiple scores and they use the same assessment tool and they have consistent results, then that's reliable, right? So those are, and there's psychometric things we can do to do that beyond the scope of this talk today, right? So things that affect reliability, the number of tasks in the test. So the bigger your N, the more reliable. The suitability of the questions for the students. If you're asking, PGY 5 questions to an intern and the intern doesn't do well, those results are not reliable. The spread of the scores, does it match a nice bell curve? Did you train your raters so that they are viewing the same thing, that they judge what adequate is, right? And that's really, that's like one of the most difficult things is training your raters so that they view the same scale of acceptability, if you will, the same way. Standardization of assessment procedure. Are the tests both given at 9 o'clock in the morning on Mondays versus 3 o'clock on Wednesdays, okay? Is the student ready? And the phrasing of the questions, okay? So all these, there's a couple more, but these are the things that affect reliability. Validity is the extent to which an assessment measures what it was intended to measure without contamination from other characteristics. My daughter is studying for her physical therapy boards, and she asked me a question the other day. She said, there's, you know, when you do therapeutic ultrasound, there's a ratio of the settings that you're supposed to set it at. And the question was you can reduce burns by decreasing the ratio, and the next choice was by increasing the ratio, right? Well, if you don't understand math, you can't get that question right. But the intent of the question was to know whether you knew how to do the settings for therapeutic ultrasound, right? That's a bad question, because you're not just measuring how much ultrasound you're supposed to give, but do you know what decreasing and increasing a ratio is? Do you guys understand? Right? So that's a terrible question, right? So different types of validity. There's content validity. You can't put content in a test that wasn't taught, right? Then the test isn't valid. Does the assessment measure the appropriate skill or trait attribute of the learner? That's construct or structural validity. Criterion, does the assessment outcome correlate with other measures? All right, so does the SAD predict college performance? You know, I'm on the admissions committee, and there's some questions whether MCAT scores correlate with STEP scores, right? And so if there's a strong correlation, then you have criterion validity. And this is really kind of interesting. Consequence. What are the stakes to the exam? If you knew that if you don't pass this test, you don't get to move forward, you have to stay as a first year, right, or a second year, versus if you take this test and, you know, nothing happens to you, will that affect your performance on the test? So that's important as well. All right, so validity is accuracy. All right, so Archer 2 is reliable but not valid, right? He's very reliable. He hits the outer ring every time, but he really is supposed to hit the bullseye. Archer 1, okay, is reliable and accurate, okay? So that's, validity is accuracy. Reliability is consistency, right? So in summary, this test is reliable and valid. This test is reliable but not valid, and this test is neither. All right? So let's talk about, so just simplistically, how do I do this when I set up, you know, a procedure? So I'm just going to use an IV, for example, okay? What we use is we call hierarchical task analysis, and we do that. That's been used in industry for a long time. And basically what you do is you describe a system and its function, and you look at all the steps within that activity, and then you analyze those steps, and you say, okay, how should this action be performed? What are the steps that are critical, okay? And then you break it down into its various components. So you observe the actual process in the clinical setting. If, let's say we're doing a clinical action, use best evidence for steps. So when Don Toole and I designed a procedural checklist for intraosseous cannulation, we went to the literature, okay, and looked at what the best practices are for performance of that procedure, all right? And that, subsumed in that is the content experts, all right? Process is iterative, meaning that if I'm going to use it as an assessment tool, I have to continually check myself. Is this the best way to assess my learners, okay? And using feedback, can I change it so that it's more valid and more reliable? So these are the steps in task analysis, okay? To define the purpose of analysis, define the boundaries, okay? He needs to start an IV, so the steps are going to be the beginning of the IV start to the end where the IV is secured. Right? So basically go to my content experts or whatever sources I have to make sure that the steps that I have are proper. Within that, describe what the steps are, and then you have to keep it fairly low or you're going to go insane, the number of steps that are involved. And then you link what each one is. For example, and I'll show you an example of IV start, is you need to give the patient information about what you're going to do. At what point do you do that? Right? Do you do that before you get your stuff? Do you do that after you get your stuff? Do you do that as you're sticking your patient, right? And then you verify that everything is cool. You write up your analysis. You send it back to the folks that know what should be done, and then you revise it. So let's take an IV start, right? The anchor is the step around which the behavior occurs. So insert the IV, right? So you've got collect necessary equipment, inform the patient, don protective gear, apply tourniquet, identify target vein prep area, inform your patient before you stick them, I'm going to stick you, stick it, confirm blood return, connect it, and then secure. So these are the steps in starting an IV, right? So I look at my task, what are the things that are involved in this task, and then you break it down into its component parts, right? So this is important. To reduce variability, you need to have specific operational definitions. When you say collect necessary equipment, what does that mean? It might mean something to you. It might mean something else to you, right? So you may fail the learner, and you may not, right? So when you do a task analysis, you have to actually say, this is what I'm talking about. And all your raters have to be aware of that, all right? So this is equipment, right? So you define it. Tourniquet, skin preparation, gauze, IV catheter, all the stuff you need. And to define further, at the start of the procedure, the learner has each of the following items within reach, right? Having an IV cath doesn't mean 20 feet away and you have to go get it halfway through after you put the tourniquet on your patient, right? So you define what's appropriate. And then you might even have to do even more detailed description. All the equipment required for the IV insertion procedure shall be gathered and organized prior to performing the actual insertion. Step 2 of the protocol, patient education, may be performed prior to this step. If any of the identified equipment has not been obtained prior to step 4, tourniquet placement, this step should be coded as incomplete. So if you're a rater and you read this, you know exactly what we mean, right? So it's fairer to you as a rater and fairer to the learners what should be expected. Does that make sense to everyone? That's the degree of specificity that you have to do when you create this. So here's a summary. So when you do a task analysis, you have to follow the rules. You have to do the right structure. You have to actually see what is appropriate, and they have to reassess. And you have to do 3 to 10 assessments to make sure that what you created actually works. If you add more points to the steps, you're going to increase your variability, okay? You really need descriptions. And for you guys as learners, when we do assessments, you should, I owe you to tell you these are the things I expect. This is what I mean, all right? And then so for me, I have to do operational definitions for each key point. And I have to decide what is successful, right? What is successful? At what point does the learner fail, right? Or is this a formative assessment where these are going to be used as teaching points, right? All right, that's all I got. Left 10 minutes for questions. Yes, Dr. Dracy.
Suggesting a possibility of further breaking more objective steps. Where we always, no matter how far out this we go, we still don't have a definition of competence.
Fully agree.
So as a result, the more objective we could be in breaking down areas where these assessments are considered consensus or judgmental, and better chance we have of modifying the
right? And that's why we're working towards a global rating scale, but still has anchor points, right? And you and I both know, if you're going to do a global rating scale, the person doing the rating has to be more expert than the trainee. If you do a checklist, right, and they've studied this, you could have non-medical people rate with a checklist because it's a go, no go. It's yes, no, yes, no, yes, no. And what checklists miss is that gestalt, right? Because I see in my learners all the time, they come to an appropriate conclusion, and I ask them how they came to that, and I discover that their actions were perfectly rational, and I would have never thought that, right? And so how do we as assessors tease out that gestalt? And you're right, it's a consensus of experts. It's extremely difficult. And where do you make the anchor points, right? And so that's why my second slide was, why is this so hard, right? In the end, it's about, you gestalting this person's competency with some foundational support from your anchored global rating scale. It's all we got, Steve. It's a great question. Yes, Dr. Oliver.
Could you respond to the criticism that some would make of competency-based education as dumbed down education? Really, you're trying to get everybody to the least common denominator, and you're not really concerned about getting people to excellence.
Well, that's the current controversy because people are saying CBME are the goal of medical education is to make people experts and to give them expertise. And so if you have this basic level of competency, is there a tension between making us experts versus just good enough? And I think there's some validity to that criticism. But on the other side, if you have nothing, if you have no standards, then you have no way to measure. And the people who don't like CBME feel like medicine isn't practiced with checklists. That's why one of the slides I showed was, how do we break down what we do, right? Is it structure? Is it process? And we struggle with that. And, I think the answer lies in the next decade, or we'll never get. That's why CBME has been doing this, right? Because there are really good trainees and then there's not so good trainees. But the goal is, can we reach a basic standard where we can say, hey, I feel good letting this person pass? And one of the things that I struggle with is we talk about competency-based medical education, but in all our training in the United States, the training period is constant, right? So there's a tension there. If I say you don't get to go practice until you can do all these things, how come training is 3 years, 4 years, 5 years, right? You either, you're in or you're not. And if you're going to do CBME, then this person may be done in 2.5 years. This one may be done in 7. But it doesn't work that way. So I'm one of the critics who says, you say this stuff, but you don't mean it because obviously you're not going to change the training period, right? Is it a fad? Some would say it's a fad. It's a fad because you're making me do all this stuff and you haven't proved to me that it works, right? Think about all the work that's gone into creating core competencies, milestones, and I know, Dr. Tracy, the milestone project must have been like killer for you, and now we're going to do EPAs for every residency, right? That's what we've always done in the backs of our minds. Can this resident deliver a baby, right? But now we have to have, formal definitions. In the end, 20 years from now, we can decide it didn't make any difference at all, and we've spent billions of dollars in our actual resources to prove nothing. I don't have an answer. I just want to kind of open this up for discussion, right? You guys are going to be assessed. We're gonna fail or pass you. And that's not the true test, right? The true test is whether you kill patients or not, right? So thank you. I appreciate that. And I just, I see both sides. Questions from the trainees themselves? Did this help you understand it a little bit better? It's still just as clear as mud, but that's what we're doing. Just so I wanted you to understand, when you meet with Dr. Geraci twice a year, this is what he has to deal with. You think you have it hard. He has to judge you, right? But he gets to say, the thing about milestones is it allows us to be vague, right? But it protects you as well. So, thanks for letting me speak today. Thanks for letting me stick you. You thought I was going to stick you for real, didn't you?